Ladies and gentlemen, we have now come to the last round of presentations of RESPIRE 13, the 12th Symposium on Rehabilitation and Chronic Care. We invite the chairpersons, Consultant Respiratory Physician Dr. Vatsala Gunasinghe and Consultant Respiratory Physician Dr. Athavam to introduce the speakers.
So we welcome you all to the final symposium of the RESPIRE 13. So the first speaker is Dr. Chatris Suravira, the consultant psychiatrist. He's also a senior lecturer in psychiatry, Faculty of Medicine, University of Colombo. Her topic is managing anxiety and depression in chronic respiratory disease. Over to you, madam.
Thank you very much. First of all, I would like to thank the President and the Council of Sri Lanka College of Pulmonologists for giving me this opportunity. Moving on to my topic proper, management of anxiety and depression in chronic respiratory diseases. Psychiatric conditions are becoming more and more important in the current day. And when it comes to that, it's not only the patients with psychiatric illnesses, but now comorbidity is becoming a norm, which means patients with diabetes, hypertension, any medical comorbidity, they might be having a comorbid psychiatric illness. And that's why it's important to talk about psychiatric aspects. And anxiety and depression are the most commonest forms that you would come across. So what is the mental health burden on patients who are having respiratory illnesses, particularly the chronic illnesses? Patients with chronic lung diseases, COPD and asthma, commonly have psychiatric comorbidities, and most of the time it will be depression and anxiety. And the prevalence of comorbid depression would be about 40% in COPD and 27% in about asthma patients. And anxiety, depression, panic attacks, if we take them all together, which might not reach the diagnostic threshold of a disorder, might be seen in about 45% of COPD patients. And a recent systemic review and a meta-analysis revealed that depression, the rates of depression is about 2 times higher among the patients with chronic respiratory diseases, and rates of anxiety is about 1.83 times higher as opposed to the general population. And 1 in 4 COPD patients has persistent depressive symptoms, which we have to be very, very careful of because we might miss these patients. And they would develop new depressive symptoms during 3 years, about 7%. So when we talk of the impact of mental health issues on the respiratory diseases, it would lead to poor adherence. Patients are sad, not motivated to take the medications, so their respiratory disease will get bad. And increased hospital admissions because they might default the treatment. And long hospital days because they might not reach out for treatment until it's very, very bad. And prognosis will be poor, premature mortality, and increased risk of exacerbations, particularly in COPD. Most of the time, untreated depression can lead to all of this, as well as anxiety symptoms, because it is just not depression leading to lack of motivation and lack of compliance, but anxiety symptoms not wanting to go and reach out for help. And when it comes to COPD also, there is increased physical disability, reduced social interactions. We might be thinking that it's because of the physical illness that they have reduced the social interactions because of short of breath or something like that. But it could actually be because of the psychiatric comorbid illness and poor survival rates. So usually patients with panic disorder, depression, anxiety, they might have poor asthma control also, which is again a chronic illness. And the other factor coming in to complicate the matters, nicotine, cannabis, heroin, which are very much associated with respiratory illnesses. So what are the barriers to psychiatric care? Why do people with respiratory illnesses, which are particularly long-term respiratory illnesses, have psychiatric comorbidities? There is overlapping between physical and respiratory related symptoms. If the asthma is pretty bad, you might be having shortness of breath, and you might be getting scared of the shortness of breath, and which will lead to anxiety. So you can't differentiate at which point the shortness of breath is due to asthma or COPD, or where the panic attack starts. And let's say the patient is having lethargy and is having lack of energy, which is a physical symptom of many, let's say TB. It might be due to depression associated as well. And let's say somebody is diagnosed with depression and anxiety, there is stigma, discrimination associated. Most of the patients who are referred from the chest clinic are reluctant to come to our unit, which is like just close by, whereas we have to sometimes go and see the patients at the chest clinic, purely because of stigma and discrimination. And they would suffer up to the point of having suicidal ideas, not coming for treatment, purely because of stigma and discrimination. And we are overburdened. We are burdened at the psychiatric clinics as well as the chest clinics. So we might not go that extra step to assess this patient to see whether this shortness of breath is actually due to chronic asthma or COPD, or whether this lack of energy or poor sleep is actually due to depression or anxiety. So that's where lack of recognition comes into play. And then the lack of treatment, lack of access to psychiatric treatment. Now, the common problem that we come across is like sometimes psychiatric medications are not available in, let's say, for example, the chest clinic. So the patient either has to buy it from outside or come to the psychiatric unit. And also, not many psychiatrists are there at the moment in the country, so that's another issue. And the solid evidence base might also hinder the clinicians from managing, because there are no evidence or research data for asthma and depression per se, or anxiety and depression, anxiety and COPD per se. We have to assume that the trials that have been carried out for normal patients without respiratory comorbidities can be applied here. So that's another issue. And sometimes we might not be sensitive, as I mentioned earlier, to see whether this presentation might have a psychiatric component embedded in it. And polypharmacy. They are already on so many medications. So what do we give the patient? And again, stigma, discrimination myths can play a role. So just going on to what depression and anxiety is, because now, as I said earlier, lack of energy, shortness of breath, these can be there in physical illnesses as well. But then how do we differentiate? That's why I said it's always important to take that extra step. So if we go by ICD-10 criteria, if a patient is having persistent sadness, if the patient has lost interest and is not enjoying anything, despite the fact that the asthma is under good control, and reduced energy is present in a patient with TB with the other symptoms that I have mentioned as major criteria, you have to think twice whether we are dealing with a TB patient who is having depression as well. And the minor criteria like reduced concentration, guilt, unworthiness, I would get better with this treatment, lack of hopes, disturbed sleep, appetite. So if all of these symptoms are there together, or as I have mentioned in the right side of the slide, then you can suspect that this is depression. So that's how we can differentiate whether this is totally physical or whether there is a psychiatric element contributing to it. Anxiety, we all get anxious. So how does anxiety become an anxiety disorder? Because anxiety is the usual response of the body to threat. If there's an examination coming up, we get anxious. Or if there is a dog coming to bite us. So it's not always pathological. And when we break the bad news that you've got TB, the patient might get anxious. But how do we differentiate and decide whether this patient needs psychiatric referral or not? If the symptoms that are there in this blue column are there, then it's most likely that it's an anxiety disorder. Intense, disproportionate, ongoing, lasts for weeks, autonomic response all the time, interferes with day-to-day life, worrying, apprehensive. So then you can think that this is an anxiety disorder. So most of the time, anxiety disorders that are comorbid with respiratory illnesses are these. If the feeling of dog in front of you and chasing you, making your autonomic nervous system hyperactive, that feeling is always there, then it's generalized anxiety disorder. But if it's happening occasionally, like asthmatic attacks, and it goes away without treatment, without the inhaler treatment, it's without a stimulus, then it's a panic attack. But if it's arising in a particular circumstance, like doing a presentation like this, then that's a phobic anxiety disorder. So that's the easiest way that you can differentiate what, where, and how these anxiety symptoms occur and what you need to do thereafter. So when it comes to management of anxiety and depression, diagnosis is important. Then identify the those who are at risk. Anybody is vulnerable to have suicidal risk, and minimize the negative effect of illness. And then you have to consider the social circumstances as well. This is a patient who is having TB with depression and having financial issues. We don't know what's contributing to the depression. Then, depending on the person might be given psychological therapies. Not all the patients who are having anxiety and depression need to be given pharmacological therapies. If it is mild or moderate, and if you think the patient is suitable to undergo psychological therapies, you can choose that. Then, what psychotropic do we choose? We have to be very, very mindful about interactions, which I will be talking about later on. And patient education. Most of the patients don't know that it takes about 1 or 2 weeks for the antidepressants to start acting. And that the anxiety symptoms will get worse during the first 2 weeks because of receptor hypersensitivity. This is the time that the patients will stop taking the treatment. So not all the anxiety disorders needs to be treated pharmacologically, as I mentioned earlier. Most of the patients do respond, about 60 to 80%, but it's going to be a chronic relapsing illness, just like COPD or bronchial asthma. And when it comes to responding rates, it's about 50% who will recover. And then Some possible explanations. Why is this patient having persistent shortness of breath despite very good asthma control? You have to think of anxiety. Just like that, don't treat anxiety when it's not responding to medications as well. It might be something else. Because sometimes ball goes from the psychiatry unit to the respiratory unit back and forth. We have to consider the biological, psychological, and social factors when managing. Pharmacological basis there. There are problems with the neurotransmitters. Patients who are worrying would get more worried. So there are psychological factors. People with anxious, avoidant personalities, they are more prone to get anxiety, depression, and then they would be scared at getting the TB drug as well. So the way they are responding is going to be different. And the social events. People with TB, COPD, nobody is immune to social factors. So moving on to management, antidepressants are the treatment of choice for anxiety disorders and for depression. Psychologically, not counseling. Anxiety and depression has specific psychological management strategies like cognitive behavior therapy, psychodynamic psychotherapy, which is not really practiced here. So those things needs to be considered. And social factors. No point treating the TB and treating the depression if the lady is getting beaten up at home. Because she's not attending to work, because he has lack of energy, because of TB and depression both. So we need to manage that as well. So first line treatment is selective serotonin reuptake inhibitors. Fluoxetine and sertraline are the ones which are available in the government sector. Most of the time we see that fluoxetine being prescribed for everything almost, but there are specific indications and interactions we need to consider when we are prescribing and when we are deciding which antidepressant to choose. Usually escitalopram is prescribed when we are suspecting interactions, but in the case of anti-TB drugs, it's better to prescribe fluoxetine or sertraline. Although the risk of serotonin syndrome is high, because if you go for escitalopram, the interactions are more. Venlafaxine is available in the government sector. Duloxetine, although good for pain symptoms, not so good for depression or anxiety. And these are effective for depression and anxiety disorders, the ones that I mentioned earlier, except for phobic anxiety disorders, specific phobic anxiety disorders, where the behavioral treatment would work. Although tricyclic antidepressants are kind of getting out of practice, they are very important and they are effective. Although the side effect burden is a problem, but not in the doses like 12.5 milligrams of amitriptyline or 12.5 or 25 milligrams of enipramine. Usually to treat anxiety and depression, you have to go up to about 100, 150. So titrating is a problem. The patient will only fall asleep at 25 milligrams of imipramine or amitriptyline. So, as I mentioned earlier, we have to consider the individual antidepressants. For anxiety, higher doses might be needed. So, that's very, very important. And please check the interactions, because sometimes we get the goosebumps when we check the interaction and see as to what might happen. So, for example, if the patients are on prednisolone, they are more prone to get mood swings like manic episodes, hypomanic episodes, depression, everything. But theophylline lowers the lithium concentrations. So they might end up having a manic relapse. Or, for example, anti-TB drugs, as I mentioned, they have interactions. So be careful when we are prescribing, just to check whether there are interactions taking place. Tolerability, SSRIs are usually well tolerated, but gastrointestinal bleeding, particularly if you are prescribing with aspirin, clopidogrel, and so on, it's better to have a PPI prescribed. Hyponatremia is an issue, particularly in the elderly. Serotonin syndrome, if you're sort of prescribing 2 antidepressants, which is not recommended, or if you're prescribing something like isoniazid, which increases the serotonin level. Benzodiazepines, oh, you can't see that, I think, but this is benzodiazepines for anxiety symptoms. Most of the people think that this is the best and this is the favorite among many. But what it leads to is probably benzodiazepine dependence, which is iatrogenic. Patients do not get better with benzodiazepines. It's just short-term symptom relief. The only indication is to maintain the first 2 weeks where the anxiety symptoms get worse because of the SSRIs that you could use the benzodiazepine for. Antipsychotics is for augmentation, so it's actually specialized care. By this time, it's better to refer the patient to a psychiatric unit. Pregabalin, gabalin, yes, people tend to use it, but the evidence base is not very strong. Propranolol, again, no evidence, only for task-specific anxieties. It's only situational, otherwise no point prescribing it on the long run. For both depression and anxiety, psychological therapies are very, very important. Lifestyle modifications, self-help, relaxation therapy, particularly because these patients are having problems with breathing that runs like a vicious cycle, and the cognitive behavior therapy, which has the thoughts, feelings and behaviors involved, and again, a specialist therapist should do this. So in summary, you have to be vigilant whether this patient is actually having a psychiatric comorbidity, and you have to assess the risks, and if there are risks, you have to refer the patient to a psychiatric unit, and the suitable management should be chosen, whether it's pharmacological, psychological, social, or combined aspects, and follow-up is very, very important because it's chronic and relapsing. Thank you.
Thank you, Dr. Chathuri Suravira, for that enlightening lecture. We learned a lot. So it's time to move to the next lecture of the symposium, Oxygen in the Management of the Chronic Hypoxic Patients. It will be delivered by Senior Consultant Physician Dr. Manil Piris, who is from District General Hospital, Martale at present. Over to you, sir.
Thank you. Thank you very much for inviting me to deliver this lecture. I know it's late in the day, and after a long session of a lot of respiratory input, I think everybody wants to go home and rest. Anyway, oxygen therapy has come into the limelight with all the pandemic, where oxygen played a major role in management, and therefore more and more people are aware of oxygen therapy, and I'm going to talk about chronic hypoxic patients. And as you know, oxygen therapy, what it means is you're giving oxygen at concentrations greater than in the environment, and the goal is to deliver enough oxygen into your organs. And it's a key component of respiratory care. And what this means is that we are choosing patients with chronic hypoxia, and the selection of patients require a definitive documented diagnosis responsible for the chronic hypoxia. You need to have hypoxia is run down from whatever the diagnosis, and the patient should be on optimal medical management while in a stable condition, and oxygen therapy has shown to improve hypoxia and provide clinical benefit. Of course, there are lots of clinical benefits by giving chronic long-term oxygen therapy: improved intellectual functions, improved severity of right heart failure, decreased red cell mass, and in patients with polycythemia, it is very beneficial. Increased exercise capacity, better quality of life, which is very important in these patients, depressive dyspnea. Dyspnea is a major feature of many of these conditions, patients who are hypoxic, and delayed development of copulmonale, reduced hospital admissions and exacerbations, and of course, improved survival. So the indications for use of long-term oxygen therapy is very important to note, as we can see that sometimes it is given inappropriately. And in COPD, patients with stable COPD and a resting PaO2 of less or 7.3 or less should be assessed for long-term oxygen therapy. I'm going through the British Thoracic Society guidelines on long-term oxygen therapy. And with patients who are stable COPD with a resting PaO2 of 8 or less, with peripheral edema, polycythemia with a hematocrit of more than 55, and pulmonary hypertension also should be thought of going on long-term oxygen therapy. If the patients have a resting hypercapnia and also have hypoxia, then of course we need to think of giving long-term oxygen therapy in addition to ventilation strategies. In patients with ILD, cardiac disease, and cystic fibrosis, we have similar figures, and but in patients with ILD who experience severe breathlessness, even without these parameters, could be considered for palliative oxygen therapy in some instances. In pulmonary hypertension, with a PaO2 of 8 or less, it can be indicated. And of course, in neuromuscular or chest wall disorders causing type 2 respiratory failure, ventilator strategies are the number one measure, and you may add on long-term oxygen therapy if needed. In advanced cardiac failure, resting PaO2 of 7.3 or less with a resting PaO2 of 8 kilopascals or less with peripheral edema, polycythemia, or evidence of pulmonary hypertension on ECG or echocardiography can be an indication for use of long-term oxygen therapy. Now, another important area where this needs to be taken into account is that when patients are discharged from hospital in the acute stage, there are some patients who may need oxygen, but we need to for formal assessment of long-term oxygen therapy is recommended to be done after a period of stability of at least 8 weeks from their last exacerbation. If the patient has borderline saturations between 93 to 94, then they should have their oxygen saturations monitored. And patients who exacerbate frequently and are unable to achieve a period of stability lasting 8 weeks, they can still be given long-term oxygen therapy. But of course, they should know that once they are well and their oxygen levels are stabilized, then they can go off the oxygen. So if oxygen is needed at hospital discharge, SpO2 of less than 92%, and these patients are very breathless, unable to manage off oxygen, and they should undergo arterial blood gas measurement, and then counseled that they may not need long-term oxygen therapy after they stabilize further. Of course, measurement of blood gases is the recommended way of doing this. At the moment in Sri Lanka, we have problems with these facilities, but of course, pulse oximetry alone is not recommended. But at the moment, we seem to be doing only that in some patients because of the unavailability of arterial blood gas measurements. So we need to take these patients' clinical condition into consideration along with these parameters. And of course, what is recommended is to do at least 2 arterial blood gas measurements at least 3 weeks apart. And then if it's still low oxygen levels, as I indicated previously, these people should be given long-term oxygen therapy. And their ABGs should be redone after oxygen titration has been done to see for worsening hypercapnia, as this can be a problem with oxygen therapy, especially in COPD patients. So once we have done the oxygen titration and when we are looking for hypoxia, while the patients are on LTOT, capillary blood gases can be the method choice without doing ABGs. But if you're thinking of hypercapnia, you need to do arterial blood gas or a cutaneous capnography can be done in place of that to see if these patients are becoming hypercapnic. So if the patient has a baseline hypercapnia, they should be monitored for the development of respiratory acidosis and worsening hypercapnia using the arterial blood gases. And after each titration of the flow rate, this should be measured. And after oxygen titration is complete, again, a blood gas should be measured. Patients who develop respiratory acidosis or a rise of PaO2 of more than 1 kilopascal have clinically unstable disease and should undergo further medical optimization and need to be reassessed after 4 weeks. And these patients probably may need some ventilatory facility as well. So usually LTOT, if you're giving long-term oxygen therapy, it should be ordered for a minimum of 15 hours per day. It can go up to 24 hours a day. And the flow rates are initiated at 1 liter per minute and can be titrated up at 1 liter increments until a SpO2 of 90% is obtained. And ABG should be performed to confirm the target PaO2 of more or equal than 8. And non-hypercapnic patients initiated on LTOT should increase their flow rate by 1 liter per minute during step up in the absence of any contraindications. Now, another indication, or sometimes patients are put on nocturnal oxygen therapy alone, mostly due to cost considerations. But this is something which we need to be very highly concerned about, and we need to look at the indications. Patients with significant desaturation during sleep with a PaO2 of less than 55 or saturation less than 88 with sleep, with a PaO2 decrease of more than 10 millimeters mercury with sleep, with a saturation decrease more than 5% with sleep, plus signs of nocturnal hypoxia may be indicative of needing nocturnal oxygen therapy. Again, in pulmonary hypertension and daytime somnolence and cardiac arrhythmias are some of the other factors which we need to take into consideration. In these patients, we always need to evaluate these patients for sleep disordered breathing, as these patients just giving oxygen alone will not relieve their problem, and they may need other ventilatory modalities. In patients with cardiac disease with nocturnal desaturation, severe heart failure patients who do not fulfill the indications for LTOT may be indicated to have this nocturnal oxygen therapy. Evidence of sleep disordered breathing leading to daytime symptoms where they do not have desaturations but have sleep disordered breathing with symptomatic symptoms of this condition may be put on nocturnal oxygen therapy alone. Other causes of nocturnal desaturation need to be excluded, like obesity, hyperventilation, or OSA, and heart failure treatment may need to be has to be optimized in these patients, because that is of course the primary cause of their desaturation, and treatment with modalities of ventilator support should be considered if it is persisting. Nocturnal oxygen therapy alone in COPD is not recommended, and other causes should be found out, whether they have other diseases like obesity, hyperventilation syndrome, respiratory muscle weakness, or OSA, and also in other conditions like cystic fibrosis, ILDs, neuromuscular weakness, obstructive sleep apnea, and obesity, hyperventilation syndromes, and overlap syndromes. It is not given as the first line treatment measure. Ambulatory oxygen therapy is something a bit new in Sri Lanka, although it has been in use in many countries over the years. Patients already on long-term oxygen therapy who are very mobile and having a good mobile outdoors can be offered this service, and it is also offered for patients for use during exercise, in pulmonary rehabilitation programs, or during exercise programs. And it should be offered after formal assessment demonstrating improvement in their exercise tolerance. It also may offer additional benefit for patients with active lifestyles or active treatment regimes, and patients with disabling breathlessness who desaturate on exercise, except patients with ILD. Patients with high respiratory rates common in cystic fibrosis and interstitial lung diseases can receive ambulatory oxygen therapy at a selective flow rate via a venturi mask rather than nasal cannulae. And these devices are now available in Sri Lanka as well. You can see outside in the stalls these ambulatory devices as shown here. Palliative oxygen therapy is another area which we need to think about. Patients with cancer or end-stage cardiorespiratory diseases with intractable breathlessness, but can be given oxygen therapy and is used sometimes. But if they are non-hypoxic and have mild levels of hypoxia above current LTOT threshold, this is not recommended, and assessment should be done for use of opioids or other measures like the fan therapy, which can alleviate the symptoms. But in patients with intractable breathlessness, unresponsive to all other treatment modalities, we may try oxygen therapy as a palliation. Short burst oxygen therapy is should not be ordered for use prior to or following exercise in hypoxemic or normoxic patients with COPD, and also should not be used on discharge from hospital for non-hypoxemic patients in severe COPD. In cluster headaches, use of short burst oxygen therapy can be an indication. As you all know, the best way to give this is via oxygen concentrators, and use of nasal cannulae is the first choice of delivery device for these patients. But in some patients, a venturi mask may be needed when you need higher concentrations of oxygen, and oxygen conserving devices can be used in these patients. Another consideration is the safety of oxygen. As you all know, it can worsen combustion, and it should not be used near flames. And therefore, if the patient is still smoking, you need to consider use of this oxygen. You need to counsel these patients, and active smokers should be counseled before we give the oxygen. And these patients should not use e-cigarettes and chargers within the vicinity of their home oxygen. And patients should be made aware in writing of the dangers of using home oxygen when in the vicinity of a naked flame, such as pilot lights, cookers, gas fires, and candles. Oil-based emollients and petroleum jelly should not be used on the hands or face or nose while using oxygen. In the Sri Lankan scenario, it has been quite an uphill task for these patients, especially our patients in hospitals, to give long-term oxygen therapy. Cost of equipment and maintenance is a major issue, and it is good to note that during our inauguration that our Director General has announced that we will have a method of giving oxygen concentrators to our patients. I hope this becomes practical reality very soon. At the moment in my hospital, we sometimes, if the patients cannot afford and they are still needing oxygen, we have actually given them some jumbo cylinders from hospital, which they come and replenish from the hospital when because they are unable to buy oxygen concentrators. And also, issue has come up with the power cuts, because patients needing 24-hour oxygen will have issues during power cuts. And therefore, we need to take all these into consideration. If you are using a concentrator, even the cost of electricity, it becomes a concern for the patient. So these are some of the major issues we are having with this service for our patients. But proper use of our home oxygen therapy will give better quality of life to most of these patients who are very hypoxic and I hope we can give a better service for the future. Thank you very much.
Thank you, Dr. Manil Piris, for that excellent, informative lecture. Let us move to the next topic. The next speaker is Professor Sally Singh. He's the head of the Pulmonary and Cardiac Rehabilitation, University Hospital, Leicester, NHS Trust. She will be talking to us on the importance of pulmonary rehabilitation. Over to you, Professor Sally Singh.
Thank you for the opportunity to present at your respiratory conference, and I'm very sorry that I can't be with you today. My name's Sally Singh. I'm a Professor of Pulmonary and Cardiac Rehabilitation at the University of Leicester, and I've kindly been invited to talk to you about the importance of pulmonary rehabilitation. So what I intend to cover today is have a quick look at the definition and the practicalities of rehabilitation and the importance of pulmonary rehabilitation to the individual, to you as healthcare professionals, and ultimately the health service. And then close on looking at some of the opportunities to expand pulmonary rehabilitation so the benefit of rehabilitation can be extended to a wider audience. So I'm going to start with the definition, and this definition is taken from the British Thoracic Society, but is largely reflected in all national and international guidance. It identifies that rehabilitation is an interdisciplinary programme of care for people with chronic lung disease. And what's important about the programme is that it is an individually prescribed and progressed exercise programme with a package of exercise aim to maximise an individual's physical and social performance and ultimately their level of independence. So the key components of rehabilitation are, in terms of a pathway, is the initial assessment. And you can see on the top left-hand side, assessments taking place at the Central Chest Clinic in Colombo. So there is a measurement of exercise capacity, health-related quality of life, impact of symptoms, mental well-being, etc. This slide centrally shows somebody actually completing a walking test. So field-based tests are the test of choice in low-cost environments and avoids expensive equipment. Once an individual has been assessed, their exercise capacity identified, their symptom burden documented, they're invited to participate in a programme of exercise and education. And these pictures here just show you some of the exercises that people do. And they are divided very specifically into resistance training, because we know that peripheral muscle strength is reduced in people with chronic lung disease, and that's an important predictor of survival. But also there is an aerobic component, which of course is important to the individual, that allows them largely to do more without being so breathless. And of course, there is also the education session that is delivered by a multidisciplinary team. These education topics are broadly identified here that include breathing control and chest clearance, exercise and maintenance of that exercise behaviour upon graduation from a rehabilitation programme, energy conservation, medication, disease knowledge and exacerbation management. Programmes typically last for 6 to 8 weeks. And then there is a discharge assessment where all of the measures at baseline are repeated to understand what benefit the programme has been to the individual. Now, in terms of the outcomes of importance, I guess we can look at it in different components. I've splitted this up into the individual, healthcare providers, and the healthcare system. So as an individual, clearly, the outcome of importance is going to be a reduction in symptom burden, most notably breathlessness, but an improvement in health-related quality of life, physical activity, and actually being able to achieve important activities of daily living, which for some may mean, of course, returning back to useful employment. As healthcare professionals, we're interested largely in the numbers and feel very comforted when we measure exercise capacity and health-related quality of life. And these are the common outcomes that are presented in research studies investigating rehabilitation. But of course, as a healthcare provider, you may have much more interest in the economic value of rehabilitation in terms of hospital admissions and length of stay. And I guess on a societal perspective, whether individuals can return back to work. So if we look at exercise testing just for a moment, there is a range of exercise tests that can be deployed. The most sophisticated is a complex laboratory-based exercise test where we obtain detailed physiological measures. Now, you might imagine that these are expensive to complete, not only in terms of the equipment, but also the staff that are required, and are quite cumbersome for the individual to perform. So as a realistic alternative, field-based exercise tests have been developed, most commonly the 6-minute walking test or the incremental shuttle walking test. There are other tests that evaluate function and performance, for example, sit-to-stand tests, but these have not been validated for use in the context of pulmonary rehabilitation because their use is not so well described in terms of identifying an individual's exercise capacity and therefore being able to prescribe an individualized exercise program. So just to summarize the field-based test, the 6-minute walking test is conducted along a 30-meter course. It's self-paced. So individuals choose the pace that they walk at to cover as much ground as possible in the 6 minutes. And it's validated across a broad range of respiratory diseases, but a practice walk is required. And we do know what the minimum clinically important difference is. So it's an important outcome for healthcare professionals to understand because we can benchmark our service against known important differences. The shuttle test is available in two formats, as an incremental test or a constant work rate test, which is the endurance shuttle walking test. It's conducted along a much shorter course, so in some ways is much more accessible because 10 meters is much easier to find than 30 meters. And it's externally paced, so individuals walk to the speed dictated by signals played from an MP3 file. Again, it's validated in a number of respiratory diseases. There is a practice walk required, but also we know what the minimum clinically important difference is for the shuttle tests, as we do for the 6-minute walking test that allow us benchmarking. So in terms of these outcomes, we can look at the Cochrane review, and it identifies very clearly in randomized controlled trial data that rehabilitation improves health-related quality of life, and I specifically pulled out breathlessness, which is an important measure to the individual, but it also improves overall quality of life, again, hugely important to individuals, and exercise capacity, which as healthcare professionals we are very focused on. And this data identified changes in the Cochrane review, looking at changes in the 6-minute walking test and the incremental shuttle walking test. Interestingly, the authors of the Cochrane review concluded that actually we don't need any more randomized controlled trials comparing rehabilitation to conventional care, because the value of rehabilitation is overwhelming and we need no more data to prove that. But what we do need to look at now is the ideal length of rehabilitation, the location, the degree of supervision, etc. So, the field of delivering pulmonary rehabilitation potentially is moving away from this conventional model of randomized controlled trials. The data that I've just shown you was that from people with chronic obstructive pulmonary disease. And of course, that is exactly where most of the evidence has been accumulated for very obvious reasons. It's a very prevalent and important disease. But there are increasingly data to show that pulmonary rehabilitation adds value for those people with interstitial lung disease and those in adults with chronic asthma. So there's not a huge amount of evidence, and more high quality trials are required. But I think that, perhaps not surprisingly, the data would support the offer of a package of rehabilitation in these two important groups of people with another chronic lung disease. So we also know that it works in real life. Obviously, research data is hugely important to help us identify benefits, but obviously implementing that can sometimes be challenging. But we know that it works in real life. And this is data taken from about 12,000 patients that pass through centre-based rehabilitation programmes in the UK. So we have a national audit that allows us to monitor performance. And you can see by this infographic, it describes improvements in health-related quality of life. And you can see that about 80% of people that participated in rehabilitation had a significant improvement in their overall quality of life, which is certainly reflective of the research data. Admission rates may be particularly important to healthcare providers and payers, and of course the government. In the UK, we have enormous pressures over winter on our hospital beds, so we're always looking for ways of keeping people out of hospital. The data from our national audit was linked to our hospital data, and we were able to show that people that completed a course of rehabilitation were less likely to be admitted to those people who did not complete a course of rehabilitation. The audit also went on to show that for those that were admitted, there was a reduced length of stay in those people that had completed a course of rehabilitation. And there's similar data from the Australian group led by Anne Holland in this graph here, in terms of the chances of being readmitted as to whether you completed the rehabilitation programme or you didn't. So despite all of the evidence showing how valuable rehabilitation is, access and uptake is really quite poor. This data, again from the UK, identifies that for every 100 individuals referred for a course of pulmonary rehabilitation, just over 40 complete. And there's similar worrying data from other parts of the world. This is data from the US that identifies that less than 2% of people received an offer for rehabilitation after they'd been admitted to hospital. And we know from Cochrane data that the evidence for rehabilitation is as strong in those post-exacerbation as it is in stable disease. And you might imagine that the health economic benefit would be greater in those that have just been discharged from hospital, because they are, of course, at increased risk of being readmitted by the very virtue of having that initial admission. And you can see this is primary care data, where they looked at a large data set and found that only 16% of people with COPD were referred from primary care for pulmonary rehabilitation. And there seem to be variables that influence that. So people that were older, women, people that were more deprived or had significant comorbidities, they had a lower chance of being referred. So there is a lot of work to be done across the system, from referral right through to uptake and completion. So we've been very fortunate to work with a team in Sri Lanka looking at the value of pulmonary rehabilitation and people's preferences. And so we surveyed a large number of people with COPD to try and understand what a good pulmonary rehabilitation program might look like. Interestingly, 80% of the patients said they would be really interested in a treatment that would reduce their breathlessness and improve their physical activity. So again, outcomes that are really important to this population. And there was just under half of that population really wanted to attend a group supervised hospital-based program. Others wanted that supervision, but in a community centre. And a smaller proportion would look to do it either through a web-based program or a very small number using a manual at home. So you can see there was a real preference for supervision and support from healthcare professionals over perhaps a more remote web-based intervention. We also looked at what may influence the referral process by surveying healthcare professionals in Sri Lanka. And this is just a graphical representation of some of the data. We asked specific questions around whether you as healthcare professionals thought it was a worthwhile intervention, whether you had information or lack of time to make a referral. And you can see that generally the blue bar in the middle represents some influence. So you can see there was some concerns around the difficulty of the referral process, being absolutely unaware of how to refer, not having enough information about pulmonary rehabilitation. And for about 50% of participants, they were unsure that pulmonary rehabilitation was worthwhile. So clearly, we not only need to convince patients that this is a good idea, but actually healthcare professionals need to be convinced as well, because without that endorsement and referral, patients will be unable to access the programs. Now, we've talked a little bit about extending the scope of rehabilitation, and there are some challenges around that. If we look at the top right-hand side, most of the evidence is, of course, around community and hospital-based outpatient programs, where there is significant support from the multidisciplinary team. But of course, post-COVID in particular, there is a huge amount of interest in developing alternative forms of rehabilitation. And if we look over on the left-hand side, you might imagine that there are some software companies developing digital interventions that have no contact with a healthcare professional at all. So we have to be careful how we categorize these interventions. And rather than just saying telehealth or digital, we have to understand what the modality is, how much support there is, how much contact there is. And so we developed this model as a very broad framework to try and understand the different types of models that are beginning to emerge in the markets globally. But of course, irrespective of any new model, there has to be certain criteria that are met. This is the outcome of a workshop that Anne Holland and I chaired on behalf of the American Thoracic Society, looking at the key components of modern pulmonary rehabilitation. So this was a large Delphi survey. And we found that overall, the essential components could be divided up into patient assessment, program content, method of delivery, and quality assurance. Importantly, almost irrespective of how the program is delivered, there has to be a wraparound patient assessment that would cover these key components. So the exercise tests that we've already talked about, measures of quality of life, assessment of breathlessness, nutritional status, and occupational status. The program fundamentally has to have endurance training and resistance training, and it has to be individually prescribed and progressed. But it doesn't dictate where or how that should be delivered. But of course, importantly, as these new models do emerge, it's important that we have staff that are absolutely trained in how to deliver these alternative models and themselves are very familiar with technology. So how do we offer people different sorts of rehabilitation? And it's interesting, as healthcare professionals, I'm sure you're very familiar with offering different sorts of bronchodilators for different people. And that may depend on their manual dexterity, their ability to inhale and breathe in deeply and press the device, etc., etc. But there is very little adaptation of rehabilitation currently. So I think we're looking at, broadly a one size fits all. And I think we need to now extend our choice to look at different types of rehabilitation intervention. As part of our global project, we've been working with teams in Sri Lanka, but we've also been working with teams in India. And this is just an example of an alternative approach that we've been looking at. And this is a digital approach that is a phone-based application. And you can see that it's been very culturally adapted because we don't conventionally include yoga in Western pulmonary rehabilitation programs, but to people in India and other parts of the Asian subcontinent, yoga is a very familiar and very important activity. So we spent a lot of time talking to patients as to what they would find attractive and engage with. So the program is walking to cover off the aerobic component of rehabilitation. There is also resistance training, as you can see in the right-hand panel. But we also have yoga as a way of helping people manage their breathlessness and help with their stress management. In summary, hopefully I've been able to convince you over the last 20 minutes that pulmonary rehabilitation is a high-value intervention for individuals with chronic respiratory disease, for healthcare professionals, and overall the healthcare system. But also we know that access to rehabilitation is not optimal. So we need to consider diversifying the offer, but that has to be in the context of a standardized pathway that I described to you as part of the American Thoracic Society workshop. And we need to embed this wraparound assessment to deliver the individualized exercise program, but also to evaluate these other emerging models. I think we'd all agree, looking at the survey data, and the data from Sri Lanka is not unique by any means, that we need to educate the workforce to offer a timely referral to a pulmonary rehabilitation service. But of course, as a collective, we need to deliver and develop those pathways so that there is a pathway and a service for people to access. Thank you.
On behalf of Ceylon College of Sri Lanka College of Pulmonologists, I would like to thank Professor Sally Singh for that excellent lecture. We'll move on to the next lecture, Uses of NIV in Neuromuscular Disorders, by Professor Anita Simmons from Imperial College London.
Thank you very much for the invitation to take part in your annual academic session. I'm Anita Simons from the National Heart and Lung Institute, Imperial College and Royal Brompton Hospital, London. My topic is the use of non-invasive ventilation for neuromuscular disorders, and I'll try and make this as practical and as useful as possible. So what I will cover in this presentation is how to identify high-risk cases, so cases that are most useful to follow up, I'll talk about clinical assessment of these patients and the diagnosis of hypoventilation in neuromuscular disease, the start of non-invasive ventilation, and I'll deal in particular with two areas: inherited neuromuscular disorders such as myopathies and muscular dystrophies, and also motor neurone disease, ALS. I'll mention some comprehensive care algorithms and then talk about some more difficult areas, combination of assist devices, what happens with progression of the disease, use of mouthpiece ventilation, tracheostomy ventilation. I won't have time to go into great detail. And then a very interesting area, the implications of the new therapies which are coming online for the treatment of currently inherited neuromuscular disorders. And then a very practical one of the increased use of home monitoring, telemonitoring, and outreach. So broadly, I think we can divide neuromuscular patients in those who are at high risk of developing respiratory compromise, moderate risk and low risk. There are quite varying phenotypes, so it's difficult to be absolutely categorical, but of the high-risk patients, of course, spinal muscular atrophy type 1 patients, those who are diagnosed at birth or shortly after birth, usually in the first 6 to 12 months. Those with Duchenne muscular dystrophy who will develop respiratory compromise now, probably in their early 20s. And myotubular myopathy is a particularly severe one. There are some limb-girdle muscular dystrophies, which are sarcoglycanopathies. And of course, most patients with motor neurone disease will develop respiratory compromise and respiratory failure. At moderate risk, I've listed these other disorders, some of the other limb-girdle muscular dystrophies, some of the congenital muscular dystrophies, and some acquired problems such as Guillain-Barré syndrome. And then at lower risk, you can see those with spinal muscular atrophy type 3, some congenital muscular dystrophies, and again, some acquired conditions. So having identified patients who require follow-up, what's the best way to assess them in the clinic? Well, of course, there's a taking of a clinical history, particular features such as recurrent chest infections, symptoms of nocturnal hypoventilation, breathlessness, orthopnea. But for the measurable assessments, of course, we use spirometry, and levels of concern, I think, are vital capacities of less than 80% predicted. And certainly if they're below 50% predicted, then problems would be anticipated. You will, of course, expect to see a restrictive pattern in spirometry. If there's an obstructive component or a mixed component, it's really important to look for the additional causes for that. Has the patient got airway obstruction of any kind? Have they got bronchial torsion? So you must find the etiology of that. These patients you would expect to have normal or high gas transfer coefficient on full pulmonary function testing. And if KCO is low, then I would start to suspect either additional lung problems or pulmonary hypertension. And as you know, a fall in vital capacity when the patient lies down of more than 20% indicates diaphragm weakness. MIP is maximum inspiratory pressure. A level below 60 centimeters of water is a cause for concern. If it's over 80 centimeters of water, I think that usually excludes significant respiratory muscle weakness. But of course, this is a voluntary test and individuals need to be able to make a maximum effort, and there is a learning effect. Sniff inspiratory pressure is probably an easier test to do. So a maximum sniff with through one nostril with the other nostril occluded. Normal values are more than 70 centimeters of water in males, greater than 60 in females, and a value in the range 40 to 60 or less than 40 would certainly be a cause of concern if the individual has been able to make a maximum effort. Peak cough flow, so it's now clear that it's important to measure expiratory muscle strength as well, and peak cough flow is a way of assessing cough efficacy. If that's above 270 litres per minute in adults, then they probably won't have problems clearing their secretions at the time of a chest infection. I don't think we really know the full value of diaphragm ultrasound as an assessment measure, say for ALS, motor neurone disease, but it's under investigation. And of course, we bear in mind not only are these voluntary maneuvers, so you're reliant on patient effort, but some patients will have weak facial muscles, making it difficult to achieve a mouth seal. And for those with upper motor neuron bulbar problems in ALS, then that makes doing a voluntary maneuver very difficult for them to comply with. So having identified patients who are running into problems or are likely to, then I do think we need to assess for sleep disordered breathing. A lot of people say, well, can screening oximetry be enough? It's certainly better than nothing. And you can see very characteristic pictures, as in this patient here. You can see these classic dips in saturation. And if you had accompanying full polysomnography, you would be able to see that these dips classically occur during rapid eye movement sleep. If someone slept well, then normal oximetry probably excludes moderate and severe nocturnal hypoventilation. But if they've missed REM sleep because they haven't slept as well as normal, you may miss a mild degree of hypoventilation. I think it is helpful to have additional transcutaneous CO2 monitoring, and this is in our lab at night preparing for sleep studies. And these are transcutaneous CO2 monitors. You may have them too, I'm sure, which incorporate oximetry monitoring as well. They do need to be calibrated carefully, but most of the studies show that for clinical purposes, you can get reasonable agreement with, say, arterial measurements. So we don't want to be taking arterial measurements all the time in patients overnight. So these are the Bland-Altman plots. And although there is a small amount of drift overnight, it really does not matter in the grand scheme of things if you've calibrated the equipment well. But you need to understand the advantages and limitations of transcutaneous monitoring. It's going to show you trends over time. It's certainly not going to show you breath-to-breath variation as you would get, say, from end-tidal monitoring. And you can get artifacts, and you need to be able to identify them, just as it's important to identify them when you're looking at oximetry traces. And these are the sorts of results you can get from transcutaneous CO2 and oximetry monitoring. Here's a night with REM-related dips in saturation. Almost certainly, this patient didn't have polysomnography, but this is so characteristic. And here's transcutaneous CO2 running up to around 10, 11 kilopascals overnight, with the peaks aligning with the dips in saturation. So by definition, this is hypoventilation. And the next night in this Duchenne patient, on NIV this time, saturation is normalized and the CO2 is virtually back to where it should be. Probably a little more titration is needed. The time to introduce nocturnal non-invasive ventilation is when the individual is starting to experience nocturnal hypoventilation, although there are exceptions to that. Patient with neuromuscular disease, for example, having recurrent chest infections. I think there are also, you may start slightly earlier in patients with highly fragmented sleep with motor neuron disease because they're waking before the CO2 rises. But this is the study that demonstrated that in this group of patients with nocturnal hypoventilation but normal daytime gases, they had a variety of neuromuscular diseases, but the group randomized to nocturnal hypoventilation had, as you might expect, a reduction in their transcutaneous CO2 overnight and a significant increase in their saturation. And they had other important endpoints, failure to thrive, resolved recurrent chest infections, and there were no emergency admissions with uncontrolled respiratory failure to ITU. So you're preempting further problems down the line. And this is an algorithm sort of summating this kind of assessment. So history taking, physical examination, assessing for inspiratory, expiratory and bulbar muscle weakness, scoliosis, other chest wall abnormalities. By the time the individual has REM sleep disordered breathing, the vital capacity is probably of the order of 60% predicted, and then it's running into non-REM and REM sleep by the time the vital capacity is less than 40% predicted. But at the same time, one wants to assess cough efficacy, as I mentioned. It's also important to understand whether there's an element of bulbar weakness and bulbar dysfunction, which may be occult. And then, as I mentioned, clinical features like chest infections. This is some outcome data, so looking at overall survival of children started on non-invasive ventilation. This group on the left-hand side are those with a range of neuromuscular disorders, spinal muscular atrophy, congenital muscular dystrophy, congenital myopathies, and Duchenne muscular dystrophy. This is a different group with other problems, restricted chest wall disease, obesity, hyperventilation, cardiac problems. But if we concentrate on this group, although these children had developed respiratory insufficiency in childhood with nocturnal hyperventilation or even respiratory failure, you can see there is an attrition in some patients, but others of them stabilize and begin to thrive, and you can see they're surviving now into adulthood and into their 20s, 30s, 40s. And of course, we now have Duchenne patients in their 50s and approaching their 60s. Not all of them. There is a variation in certainly in genotype and also in phenotype, but subgroups of these patients certainly survive well into adulthood and middle age. Just focusing on, instead of the those inherited neuromuscular diseases, on now turning to motor neuron disease or ALS. Just some key points on this. Multidisciplinary team involvement from the start, so neurologists, physiotherapists, pulmonary physicians, speech and language therapists, dietitians, inserting the PEG at appropriate times, so assisted feeding, definitely improves outcomes. So the more we can work together as a team, the better. I think it is helpful to have a respiratory referral on diagnosis. Look out for symptoms. Sometimes it might not be the overt symptoms of sleep disordered breathing one might expect, such as headaches, but just poor sleep quality or micro sleeps during the day. And then assess, as we just discussed, with spirometry, cough peak flow, respiratory muscle strength, and sleep study. Some years ago now, almost 20 years ago, Rebecca Lyle showed an interesting finding that there is a linear decrease in sniff and respiratory pressure in these patients. But if you're relying on vital capacity, it's not necessarily linear. There can be a gradual fall, and then you see a sudden drop off. So just beware of this finding. So this was the, I think, seminal study really done, a randomized controlled trial of non-invasive ventilation in motor neuron disease, showing that when started at the time the patients became hypercapnic or they were orthopneic, so they were relatively advanced, there was a significant survival advantage. So the NIV group is the blue line here, whereas the control group is the red line. So significant survival advantage in all patients. But with NIV, the survival advantage is greater in those with mild to moderate bulbar weakness compared to severe bulbar weakness, where there wasn't a significant survival advantage in these advanced patients. With regard to quality of life, again, it was increased more in the mild and moderate bulbar group, but even the severe bulbar patients had some improvements in quality of life measures, particularly those related to nocturnal hypoventilation. I think we've moved on since that trial. There is now, I think, a move to start non-invasive ventilation slightly earlier in the natural history. And this is some work, Italian work, showing survival, no NIV. This is NIV, but suboptimally applied. Here, patients having still persistent obstructive sleep apnea. This is patients with persistent leaks, but with optimized NIV, better survival. So a big argument to make sure you've actually dealt with the upper airway obstruction as well as the hyperventilation element. Here is with the addition of the in-extra theta showing further survival too, and the suggestion that you can get the longer survival with tracheostomy, invasive mechanical ventilation. Patients should be given the option of this, but it's not always possible or not always what they would wish to do. And that's a careful discussion. I'm not going to go through this in detail, but this is the ventilatory care algorithm for evolving neuromuscular disease, showing the trials of non-invasive ventilation, cough assist, disease progression, so daytime ventilation, the need for assistance with feeding. Important point here is I think the palliative care team should be involved throughout the course. So this is not just involvement of the team and our advice on palliative care at the end stage. This is throughout the course of the illness. Peak cough flow, whether it's in motor neuron disease or inherited conditions, of course, some motor neuron disease is inherited, can be measured simply with a peak flow meter in children too, so with a mouthpiece attached. And it's important that these devices, so physiotherapy first, have a hierarchical approach. You can then use an ambibag to assist cough, but if that is not sufficient and cough peak flow is low, then mechanical inexaffation significantly improves the efficacy of cough, and of course can be used not only to prevent problems at home, but as in this patient, a Duchenne patient with a chest infection, intensively on the ward or in intensive care to aid recovery. Diseases progress over time, and in some of our neuromuscular patients, it can be helpful adding mouthpiece ventilation during the day. This is a nice study from Michel Toussaint showing these little peaks you can start to see in CO2 during spontaneous breathing during the day. Although this patient was using NIV at night, you can see with the mouthpiece here, they can have sips from it, so have additional breaths during the day, which can be helpful for, say, Duchenne patients when they're at college, university, or in work, or other patients at school, to assist their breathing during the day. Their face is left free. Of course, that doesn't work in all patients, particularly if they can't achieve an effective mouth seal, and you need particular settings on the ventilator for it. Just to emphasize the point that it's not enough just to start non-invasive ventilation, you need to continue to optimize it. And this is a nice French study showing that having started non-invasive ventilation in neuromuscular patients, this is a whole mixed group of patients, if there is still residual hypoventilation in these patients, i.e. the settings are not optimal, then these patients will have an increased risk of ICU admission, and actually the event-free survival is reduced. So a good argument to continue to ensure that your settings are optimal. I'll go through this quickly because I'm sure all of us are doing much more in terms of telemonitoring for our patients. We can monitor the efficacy of ventilation from the equipment. We can measure adherence. We can measure leaks, ensure we've got the right interface. We can look at oximetry at home. And especially during the pandemic, that has been used increasingly. A big change at the moment is the impact of new therapies. There are many of these. In the interest of time, I'll just mention a few. In spinal muscular atrophy, the first important one of these was nusinersen. This is an oligonucleotide which does significantly impact on the natural history of type 1 spinal muscular atrophy. You can see here that in this randomized group of patients, these are babies started on nusinersen, it's intrathecal therapy. They were started at less than 12 weeks of age, a significant increase compared to the placebo group in ventilation-free survival. But this differentiation was not as great in the older children. So you need to start treatment early, but it means that we have to rethink and carefully integrate our support, non-invasive support, with this changing natural history of disease. And we don't know the sort of arc of the disease now on these new treatments. But of course, if we want to start treatment earlier, then there are a lot of trials going on, and countries now adopting newborn screening for spinal muscular atrophy. So we can start early. And slightly more easy to deliver is risdiplam, another treatment that can be used, but this time by mouth instead of intrathecal. This just shows you now some dosing. So this is the sort of dosing that can be used very early. But if you do get in very early and you can use gene therapy in some patients too, you get an even more significant impact. This is treatment started at 22-year-old babies, and you can see that some of them are now sitting, so you're moving them from SMA type 1 to SMA type 2. Few of them need feeding assistance. But a caution is that gene therapy in SMA has been paused for older children over 12 months, and also they're likely to be heavier due to the findings of abnormality in liver function tests following gene therapy for SMA. So I think we have some question marks over that, but it's still continuing in the younger children. Likewise, the landscape's changing in Duchenne muscular dystrophy. There are a whole range of approaches that can be used, as you can see here. I won't go into detail. Some of the most exciting ones, microdystrophin delivered by adenovirus gene therapy, and also a big interest in gene editing. So I think we can expect changes in the future there, and we'll need to reflect on that and see how we integrate our therapies. Other development, I think, that we're using a lot in a whole range of our acute and chronic patients is high flow nasal oxygen therapy. This may be an option in some of our patients in SMA, especially for acute chest infections, but it hasn't been trialed long term. We don't know the impact fully on CO2, although it's not as likely to raise CO2 as much as was felt initially, but might be appropriate in those who tolerate NIV poorly with perhaps early phases of respiratory insufficiency and motor neurone disease or spinal muscular atrophy. But one would need to very, very carefully assess CO2. So in summary, what we want to do in these patients is identify those who are most likely to deteriorate, understand the pathophysiology, assess our patients clinically carefully and start NIV at the appropriate time, confirm the efficacy of long-term therapy, and then make sure we adapt this to the goals of our patient and the evolution of disease. It's far better to anticipate problems, but we need to problem solve as well and palliate symptoms throughout. I definitely think that COVID has accelerated telemonitoring and a whole range of initiatives in home care and outreach programs, but we should evaluate these programs carefully. So with that, I'd like to thank you very much indeed for the chance to participate. I'm only sorry I'm not with you in person, but I'd be very happy to answer questions. Thank you.
Thank you, Professor Anita Simmons, for the informative lectures. That concludes the end of the sessions. Now we move to the Q&A session. So all four speakers are available to answer the questions. You can direct your questions to the speakers.
Question is to Professor Sally Singh. Regarding pulmonary rehabilitation, how do you assess the nutrition aspect of the patients in your programs? The nutrition aspects, and what are your recommendations?
So thank you very much for that question. I hope you can all hear me.
Yes,
yes,
we
yeah.
can. Yes.
And it's a very interesting question because the work that we're doing in Sri Lanka is working with a dietitian. So she's very specifically looking at body composition and offering participants who are underweight additional supplements, protein supplements, as they pass through the rehabilitation program. So for that, we've been looking at simply a measure of BMI, which of course has some problems, but is probably certainly a good start. And we've been looking at skin pole thickness as well. So fairly simple and accessible measures, and we'd be delighted to come back next year and report back all of the data that we've collected, because the dietitian has not only taken part in the feasibility trial, but also has a cohort of approaching 150 individuals with COPD, where she's done very detailed nutritional analysis, not only of their body composition, but also of their daily food intake as well.
Thank you.
So my question is from Professor Shalish Singh. So in Sri Lanka, the transport become more costly than before. Now, is there any evidence? Is it the home-based pulmonary rehabilitation? Is there any evidence in supporting of the use of a home-based pulmonary rehabilitation in people who cannot able to attend to the comprehensive pulmonary rehabilitation?
That is obviously sort of the million-dollar question, and there's a lot of people putting a lot of effort into developing different forms of rehabilitation. Of course, home rehabilitation is one of those areas that's been explored. There have been a couple of fully powered randomized controlled trials that have looked at home-based rehabilitation. One used a manual that I think I probably talked about in the talk that originated from the UK. And the other one was an Australian study that had a series of telephone calls to support individuals. I think a lot of our data, and I think this is true for the population in Sri Lanka as well, is that the appetite for digital interventions is quite low and people's engagement with them is poor. And so certainly in Europe and you know, North America, we're being encouraged to adopt a lot of digital light touch interventions with very little supervision. There's not a lot of evidence for those at the moment. People have looked at video conferencing, for example, and having sort of live supervised sessions with the video conferencing. When that's been compared to supervised rehab, the results are slightly underwhelming, I think. And I think there are some challenges with trial design, but it's a very hot topic at the moment, and a lot of people are investigating it because, of course, everybody's now challenged with additional travel difficulties, and that was always considered a problem for rehab. So I think we have a responsibility to increase the scope. I suspect the secondary debate is how much is enough. So are we prepared to compromise perhaps on the absolute value, despite the fact that it may be delivered in a home environment? But I think it's beholden to all of us to explore alternative interventions, because even when there wasn't the economic pressures that people are facing now, access to centre-based rehab was not wholly accepted by a significant proportion of the population. So clearly there's a need to look at different ways of delivering rehab.
I have a question for Professor Anita Simons. First of all, thank you very much for that very comprehensive talk. I just want to know, once you establish NIV, how often do you monitor and what parameters do you look at?
Thank you very much. It's an excellent question. I think obviously you want to get the patient stable. So if they're stable, it would depend, I think, on the underlying disease and whether the disease is progressing and whether there are any other factors. Some patients have cardiac involvement, but by and large, we initially see people at about after a month, and then we would follow up, say, at 6 months, and then if they're stable, very stable, then we would see them yearly, but have access. And I think what we're trying to find the balance between video consults and face-to-face consults. And there's a balance between them. There are advantages and limitations, because for groups of patients who are immobile, it's a huge effort to come up to the clinic. And it's much easier to see people at home, but the downside is clearly you can't examine them. You can't get tests other than relatively simple ones. So they're the issues, I think, in terms of assessment and the frequency of follow-up and the type of follow-up that you offer patients.
Yeah, my question is from Professor Anita Simons. So this is regarding the acute management of neuromuscular respiratory failure. In people who have bulbar weakness, I have the experience of managing 2 patients with myasthenic crisis who went into type 2 respiratory failure. So both of them end up in developing severe pneumonia and died as a result of a pneumonia. So is in patients with a bulbar weakness, in addition to the neuromuscular respiratory weakness, is the invasive mechanical ventilation is preferred in the acute management over NIV?
I mean, depending on the extent of the problem, but I think if there are severe bulbar problems, there is, because of the pneumonia, severe respiratory failure, then I think it may be sensible to intubate the patient. I mean, you mentioned they have myasthenia, so as well as the resolution of the pneumonia, it may be possible to improve the general muscle strength with the myasthenic treatment. So you may then be able to extubate the patient back onto non-invasive ventilation. I mean, you can manage some groups with sort of moderate bulbar problems with a combination of NIV and the cough assist machine to help them clear secretions. So that might be an option, but not if there's severe bulbar problems.
Thank you very much.
I have a question to Professor Anita Simmons. The excessive secretions that some of these patients have, is that a problem with use of NIV?
Depends on if you mean upper airway secretions, so saliva and so on, as with a motor neuron disease patient. I don't think it's a specific problem with NIV, but it is a problem, and it can be a real issue for some patients. I mean, you can use hyoscine patches, you can use atropine, you can use a range of interventions, but I don't think it worsens the ability to apply NIV. In fact, sometimes, it can help dry secretions. So it wouldn't limit my options, but I would very much focus on dealing specifically and pharmacologically with the secretions. Glycopyrrolate is another option as well, and there are teams that use Botox injections if you really can't get on top of excessive saliva and upper airway secretions with other pharmacological interventions.
Thank you very much for your inputs. I would like to thank all four speakers for their excellent presentations, and that will conclude our sessions, this symposium.
Ladies and gentlemen, before we wrap up today's the final symposium, I'd like to the college would like to acknowledge the keynote speakers who were present here to enlighten us with all the information about rehabilitation and chronic care. We have arranged a small token of appreciation for our keynote speakers, and it will be distributed by Dr. Vatsala Gunasinghe. First up on stage, can we please have Dr. Chathuri Suravira. Next up, can we please have Dr. Next up, can we please have Dr. Manil Piris on stage.